came to us for um, stroke,
Mhm.
and the thought process was that the history given was aphasia 4 a.m. today, lies at adjacent hospital, NIHSS score of 22, left M1 occlusion, and I would straight give you the CT angiogram.
Okay. So
Okay,
this
so
is
here you go. I'm going to start from the top.
okay.
So they were suspecting left M1 occlusion
Okay.
on clinical basis. I'll give you the vessel as well.
So so left M1 seems okay.
Okay,
Uh,
so I'll change the window so that you can always, for the general audience, always have a window so that you can see through the vessel. So see, I can see through the vessel. So always have a window that you can see through the vessel when you're looking at the CT angiogram.
okay.
So going down,
Both internal carotids and vertebrals are patent so far. It's going fast. Okay, both common carotids are patent. Multiple thyroid nodules incidental.
yeah,
Okay,
well done. I'll change the window a bit.
okay. Then we have at the arch. There are multiple filling defects at the left pulmonary, main pulmonary, and at its bifurcation. Can we zoom out the image, please?
Yeah,
Okay, I need to check the right side as well. The right side is only partially covered, but I think there is also a filling defect extrinsic at the right side, but it's like a saddle aneurysm at the left side, saddle, sorry, thrombus
perfect.
at the left side.
Well done. Well done. So that's what I wanted you to pick up. Um, Whenever you are looking at CT angios, you must look at pulmonary vasculature, you must look at lungs. You will be surprised. You will pick up cancers, you will incidental cancers. And in this case, there was a large pulmonary bilateral venous thrombus, and that was and this patient was considered unfit for any intervention. We could not see an M1 thrombus, and given such a large thrombus, it was considered unfit for any intervention of any sort, and this patient later on died. So the moral of the story is always look at other parts of the brain and the neck whenever you are looking at the CTAs. Well done.
Thank you, sir.
Excellent. Thank you. Okay. Dr. Sami, are, uh, I'm okay with that now. Thank you.
Thank you very much, Dr. Jadoon. Brilliant cases, and I'm sure everybody learned a lot. Uh, so we hope to see you very soon again on our forum.
No
Uh,
problem.
uh,
With pleasure.
there were three candidates today. Uh, Next session, next Thursday, I think I'll take and I'll announce on Instagram where it is. Is it going to be potpourri or something more specific? So see you next Thursday. And once again, Dr. Janoon, thank you very much. If you have got 5-10 minutes, we will. Do you have you got 5-10 minutes, Dr. Janoon?
Yes, I've got no problem.
Okay, okay. So for 5-10 minutes, we will just take a few questions. If there is
Yes.
any question in the chat, please.
Where are the chats in this?
So
Okay.
I'm reading the chat. Still, there is no question because I think they were not ready. That let's wait. Let's wait.
No problem. I'm reading the chat. It is.
Differentials of CJD case. So
Yeah.
cortical restricted diffusion. Over to you.
Okay. So the, there are two things that give you this. Remember, the context of the history was very, very important. One, of course, is a global ischemia. If the patient is hypoglycemia, you has got a very low blood pressure, or oligemia has happened, and I have seen the conditions that I have seen and are commonly noted. Say the under anesthesia, if the patient is continuously on a low blood pressure during surgery, then you will have a global oligemia type of a picture. Hanging is the other one, but do keep in mind it is global. In this case that I showed, it was the occipital lobe was bilateral, mostly left hemispheric, and a bit of caudate nucleus was involved. The most important thing tagged with this finding is a very specific clinical picture, and that is the cognitive decline in days to weeks of the patient. And in my experience, these patients also have one or two epileptic seizures, and the clinicians are usually very, very dogmatic about it, and they say, listen, rule out CJD for us. And when you have this type of a context, then it is you should consider sporadic variety of CJD. And the repercussions for us in our part of the practice is that any intervention that gets done, all the equipment has to be quarantined, and that has big repercussions for theaters. Especially, I deal with neurosurgery; they have to quarantine a large part of their equipment, and they don't like it if you have not picked up CJD, and later on it biopsy proves that it was positive. It has all those patients have to be tested. Those who have gone through those equipments. So that is the important part. There was a okay. So there was a. Can you hear me, guys? Okay. So there was a question that was asked. How to differentiate? Let me just see. Left M2. No, no. The question before that, how to differentiate between spinal cord ependymoma and cavernoma, as both have hemosiderin rim. The cavernoma will have a complete hemosiderin rim. Um, that's one. Number two, it will be small. Number three, it is usually paracentral. Ependymomas are usually on the side. Sorry, in the center of, and has got a cystic component. Got bigger cord expansion as well. So that's the important thing, and enhancement is avid as well. So that's how you differentiate. uh, Thrombus. Hang on. Okay, so how to differentiate between thrombus or dissection? uh, Dissection has got a flap, vascular lumen change, and will also have a thrombus. But there is a rat tail sign on the CTA, and has got a vessel wall thickening. That's the other important thing you have to remember. And it is not at the right at the origin like an atherosclerotic plaque. It will be in the mid body or proximal third of the ICA, sparing the origin of the ICA. That's the important take home message. What was the other thing? Venous thrombus, left M2 segment thrombus. No, that did not have a venothromboembolism as well. No, the one I showed you for pulmonary vein was a separate case. Imaging differentiate between intradural and extradural. Uh, Intradural, extradural, important, depends how you're talking the spine. Try to look for the dura will be pushed inwards if it is an extradural, and if it is intradural, the dura will be pushed outwards. Try to look at where the lesion starts. That's how you will differentiate, not at the main bulk of the lesion, where the lesion starts, because that will tell you where the dura is. Sometimes you have to recall the patient to do thin section imaging, the sequences that you do for IAM. They are the ones that give you the answer. What was the okay? I see a dissection and thrombus. Would dissection prevent angiothrombolysis being done? No, not the case. We don't bother about it. We still go for thrombectomy. God, how do I go back to this chart? Okay, this is the chart. Okay. Uh, could you please display the barcode on the screen? Yeah, there is a barcode already on. This differentiation between difference in management of thrombus and dissection, thrombectomy wise, no difference. Um, if there, okay, here is important. If there is only a dissection of the carotid with no thrombus distally, it is medically managed. It is not managed invasively. We only go in the intervention only if there is a brain thrombus as well. So if there is only a dissection of the carotid, it is medically managed. We do not go in. In ICA dissection and thrombosis, would you prevent angio? In ICA dissection thrombosis, would dissection would I could not understand this question. I apologize. If there is only dissection, it is medically managed. If it is a dissection and a clot in the brain, yes, we go in and do a thrombectomy. What else? In the we consider subependymoma. Yes, subependymoma can be in the subependymoma usually. Yes, it can be in the differential. If the remember subependymomas have got reduced enhancement. In that ependymoma case, the enhancement was more. Yes, but yes, subependymoma stays in the differential. That is correct. In the cervical spine cavernoma, ependymoma, no, it was very dense hemosiderin rim, so not ependymoma in the differential. But you won't be penalized as far as you say mass effect and all and spinal surgical referral. Wouldn't you pick up the phone? Okay, when you pick up the phone and call, is it the referring physician? Okay, so here is the thing. Um, the rules of the game are in our part of the practice, the person who has requested the scan gets the information back because we don't know the history. So if even if I spoke to the surgeon and said, oh, there is a tumor, he will say, I need a formal referral by the referring clinician who referred the scan to refer the case to me. So goes back to the person or the team which ordered the scan. That's how it works here in this part of the world. Okay, sir, your first case, obex of fourth ventricle. Final diagnosis was an ependymoma. Can you pick up the thrombus in the MCA? In the last case, there was no thrombus in the MCA. It was a distal, very distal ischemic change. There was a no large vessel occlusion. The whole thing was the pulmonary thrombus. I hope that has given you all the anybody's question that I have not answered. I think I have given you everybody's answer. Okay. Location of ependymoma versus cavernoma. Usually it's in the cervical or thoracolumbar region for ependymomas. Cavernoma can be anywhere. Okay,
Okay.
so
I think, Dr. Jadoon, thank you very much. You can, whatever you wanted to say, please continue, but we are not going to take any further questions. Over to you.
okay, no, okay, we need more sessions on infections and inflammatory. Okay, I think on demand. So next time when I do, Dr. Sami, when I do a session, it will be more on infections and inflammatory. I'll try to concentrate more on that side. I won't include